let me start by acknowledging that we do a lousy job of managing chronic diseases in this country. So if you look at blood pressure, a third of patients are at the JNC7 goals for blood pressure in this country. If we go on to diabetes, and we look at the triple score for diabetes, which is blood pressure control, cholesterol control, and blood glucose control as measured by hemoglobin A1C, less than 4% are at goal for all three measures. About 1 in 8 women are screened appropriately for osteoporosis, and evidence-based guidelines are utilized about 1 out of every 14 times for patients with asthma. So why are we so lousy at this? Okay, it's not because doctors are lazy or stupid. Okay, it's because physician practices in this country were really designed to manage acute care, not chronic care. My father's a family physician who went into practice 50 years ago. Most physician practices, the design hasn't changed substantially in that 50 years. So if we want to see these statistics change, we have to change the way physicians practice, and we have to give them tools that help them efficiently manage chronic disease. And go to the next slide. Okay, so what do we need? Go ahead. So it's really a handful of core tools that are going to be required, and I'm not going to read this list to you. You can all read. What I do want to do is give you a very high-level overview, since I've only got about 8 minutes, of the kinds of tools, representations of the kind of tools that we need to effectively manage chronic disease. Go ahead. We'll use, and then once I give that overview, my colleagues on the panel are going to give you some very specific examples. We'll use diabetes as our example because we're facing an epidemic of type 2 diabetes in this country. We go to the next slide. So here's a screen for our patient with diabetes. Much of medical care, and in particularly much of chronic disease management, is based on periodicities. So for a patient with diabetes, we want to regularly track their weight as measured by their BMI. We want to regularly check their blood pressure. We want to get a yearly retinal exam. We want to get a regular foot exam, measure their hemoglobin A1C regularly, et cetera. So for this patient with diabetes, we have 11 parameters that we need to track on a regular basis for her. Okay? If this is a Medicare patient, she probably has 3 or 4 or 5 additional chronic diseases, each of which has parameters that we need to track. Okay? And oh, by the way, doctor, you have 15 minutes to see the patient, do the history, do the exam, provide the patient instructions, and document everything that you just did so you can get paid. So in other words, it's impossible without good tools that make this process efficient. So with this one screen, though, we can now manage the patient's diabetes without having to go anywhere else, because all the information that we need to do that is here. So if we look at this, we've got the indicators, the parameters that we're going to track on the left-hand side. They're color-coded to know if we're at goal or not. We've got the goal or indication. We've got the schedule, which we can change with a single click. We've got the most recent result. The trend line, we click on the spark line, it blows up, shows us the actual details. We have the date it's next due. If it's overdue, we get alerted to that. Okay, so we see it right away. And if we want to order that, we simply check the box. So suddenly, we've made this process very quick and very efficient for the provider, but also, importantly, for the care team. Okay, because providers can't do this on their own. The care team can now use this. Okay, you don't need a physician to know that the patient's overdue for her creatinine and urine microalbumin. Okay, the system alerts us. You don't need a physician to see that the patient's not at goal for her BMI. So my staff can automatically intervene and do lifestyle counseling. Let's go ahead. We can also provide links to evidence, to important reference information. There was a study that showed that the average primary care physician has 20 unanswered questions a day. 20 unanswered questions a day. A lot of those are unanswered because they simply don't have time to go look up the information. But now we can provide one-click access to contextually relevant evidence-based information. So if we want to find out more about about urine microalbumin and diabetes, we simply click on the link and we bring up the relevant information. And go on to the next slide. We can also use a rules engine in the background to provide recommendations. So we see that this patient's not at goal for her glucose control as measured by her hemoglobin A1C. So what I might want to do, go ahead. Oh, yeah, that's good. Is bring up an evidence-based protocol, okay? Now, the reality is this isn't all that useful to me as a practicing physician because, again, I don't have time to sort through all this information. But if we translate this evidence-based protocol into actionable recommendations, go ahead. Oop. Now we've got something that we can actually use. So I'm getting the signal to move through this quickly, so let's go ahead. Okay, I guess the senator's here, so we'll take a pause.
Okay, thanks for being such a good sport on that. We have a timeout in the field. Timeout, Allscripts.
I will say, in my role as Chief Medical Officer for Allscripts, we have clients all across the country, and a lot of my time is spent meeting with those clients. And I can tell you, I've seen more change, or at least more inclination to change on the delivery side in the last 1.5 to 2 years than I've seen in the previous 20 years that I've been in this business. So things are really starting, which is great to see. Okay, so how do you get quality in any industry? Do you publish documents for workers to tell them how to deliver high quality? No. You build quality into your processes, right? So how do we deliver quality in healthcare? What do we do in healthcare? Well, we publish evidence-based guidelines in paper form, and then we wonder why our quality doesn't improve. So providers need the tools to be able to take those evidence-based guidelines and translate them and build them into their workflows and processes. And this is just an example of a tool, a visual workflow tool that allows them to do that. Go ahead. Care coordination, we talked about that. In the interest of time, I'm not going to go into the details here. Suffice it to say that we are finally starting to see providers take a real interest in care coordination as some of the payment mechanisms begin to change. And we've got a pretty aggressive program to extend our inpatient care management and discharge planning tools into the ambulatory setting. Go ahead. We have to engage patients. You cannot manage a chronic disease in a 15-minute visit every 3 months. If my diabetic patient leaves my office and stops and gets a Krispy Kreme donut on the way home, I haven't really accomplished much. It's what happens in between those 15-minute visits every 3 months that matters. So we need tools that patients will adopt and engage. This happens to be an example of a web-based glucose log that the patient enters. This can be overlaid with insulin doses, for example. Go ahead to the next slide. And summarized, and all this information can be shared with the patient's provider. Next slide. And then finally, we need robust analytics so that we can look across our population of patients and understand what's going on. So this happens to be a provider-level dashboard. It shows me how I'm doing on quality measures across my patient panel. I can drill down to individual patients. So I might, for example, want to export a list of all my patients who have a high hemoglobin A1C so my office can contact them and bring them into the office for a visit. Go ahead. So to wrap this up, we can really make a difference with the right tools. This is real data from one of our clients on achieving blood pressure goal, JNC7 blood pressure goal. And you'll see that the national average, between 30 and 40% of patients at goal. Elite medical groups tend to get between 65 and maybe 70%. These guys have over 90% of their patients at goal. Okay, if we did that across the country, it would have an enormous impact on quality and cost.